Good afternoon friends. Today I'll be discussing ophthalmology part of grand test number 182. So let's begin with question number 191. Question number 191 says, which is true about sympathetic ophthalmitis? Option number A is that it occurs after trauma and surgery. Option number B, injured eye is exciting eye. C option, it occurs in sound eye immediately. And D option is bilateral non-suppurative uveitis occurs. So here the correct options are, write down, correct options are option number A, option number B and option number D. A, B and D are the correct options. So let us discuss briefly about sympathetic ophthalmitis. What is sympathetic ophthalmitis? So let's begin with question number 191. The correct options here are option number A, option number B and option number D. So what is sympathetic ophthalmitis? What is sympathetic ophthalmitis? So sympathetic ophthalmitis, it is a bilateral and it is an autoimmune granulomatous reaction. It is an autoimmune granulomatous means it is non-suppurative. It is non-suppurative pan-uveitis. It is a pan-uveitis. Pan-uveitis means that there is inflammation of iris, ciliary body as well as choroid. So it is a pan-uveitis reaction. Now coming to the cause of sympathetic ophthalmitis, why it happens. So sympathetic ophthalmitis, it basically occurs after accidental penetrating trauma to the injured eye. The most common cause, if it is asked, write down, the most common cause of sympathetic ophthalmitis, it will be accidental penetrating ocular trauma to ciliary body. So there is damage to ciliary body in sympathetic ophthalmitis. So this is the reason why ciliary body is also known as dangerous area of eye. Very rarely it can also occur after ocular surgery. So it can also occur after ocular surgery. So these are the causes. Now coming to the pathology of sympathetic ophthalmitis. So it occurs due to trauma, right? So there is trauma to one eye, right? So the trauma to one eye, that eye is called as exciting eye. The traumatized eye is called as exciting eye. Now what happens after trauma to one eye, in more than 80% of the eyes or in more than 80% of the cases, there occurs uveitis. In more than 80% of the cases, uveitis develops in the other eye or the fellow eye. So uveitis develops in the fellow eye. This fellow eye is called as sympathizing eye. This fellow eye is called as sympathizing eye. Right? So one thing you need to remember in this is that sympathetic ophthalmitis occurs in non-traumatic eye. Sympathetic ophthalmitis develops in non-traumatic eye. Now important thing to note here is that what is the duration of development of sympathetic ophthalmitis in the sympathizing eye. So after trauma to one eye, the duration is usually 2 weeks to 3 months. So usually after 2 weeks to 3 months, this uveitis develops, right? This uveitis develops after 2 weeks to 3 months. So these are the causes of sympathetic ophthalmitis, right? Now coming to next question. Next question is 192. True about central serous retinopathy is option number A, may recur in same or opposite eye. Yes, this is true. Option number A is true. B is smokestack pattern on FFA is seen. Yes, this is also true. It is self-limited. True. This is a self-limited condition. Then option number D, treatment is required in minority of the cases. Treatment is required. Yes, it is required in minority of the cases. Option number E is due to defect in photoreceptors. This is a false statement. So write down question number 192. The correct options in question number 192 is option number A, option number B, C and D. These are the correct options. So let's now discuss briefly about central serous retinopathy. It is also called as CSR, which is central serous retinopathy. It is also called as chorioretinopathy or central serous retinopathy, right? So it is usually a unilateral condition. CSR usually develops in one eye, usually, yes. Now what is CSR? CSR is, it is an idiopathic condition in which there is localized shallow neurosensory retinal detachment, right? In CSR there is localized and a shallow neurosensory retinal detachment where at macula. So the detachment is at the macula, right? So what happens due to this detachment? Why this occurs? Now coming to the risk factors of CSR. What are the risk factors for CSR? So it is commonly seen in males. It is more commonly seen in males, and the age group which is affected is 25 to 55 years of age with history of smoking, stress or type A personality. So write down risk factors. It commonly occurs in males. It commonly occurs in male patients 25 to 55 years of age with history of smoking, stress, patients who have history of smoking, who are under stress, patients with type A personality, Then it is commonly seen in pregnancy and in H. pylori infections. So these are the risk factors of CSR, right? Now coming to the pathology of CSR. Why there is CSR happening? Why there is neurosensory detachment? So there is increase in hydrostatic pressure in the choroid, so which leads to there is retinal pigment epithelium detachment, or there is RPE defect occurs. RPE defects occur and there is RPE pump failure occurs. Right? So suppose these are the 10 layers of retina, right? These are the 10 layers of retina, and this one is the outermost layer, which is the retinal pigment epithelium layer, right? So below this layer of RPE, which layer is present? There is presence of choroid. Choroid contains choriocapillaries, right? So in CSR, what happens that there develops RPE defects. There develops RPE defects. So defects occur through RPE, and there is RPE pump failure which is occurring, right? So due to which there is leakage of the fluid from the choroid, which is from the choriocapillaries. This fluid, this collects into the subretinal space, right? This collects in the subretinal space. This space is called as subretinal space. This is a potential space between RPE and the rest of the 9 layers of retina, which are called as neurosensory retinal detachment. So these 9 layers are called as neurosensory retina, and the fluid accumulation occurs in sub-RP, this subretinal space. The fluid accumulates in subretinal space, right, which leads to neurosensory retinal detachment. So this is about the pathology of CSR. Now, after discussing the pathology, this is a unilateral condition, right? So coming to the clinical features, the patient will have complaints of same. The patient will have chief complaints of same complaints as the patient have of macular disorders. The patient will have loss of vision of the central vision. Why central vision is lost? Because macula is responsible for central vision, right? Then the patient will have complaints of metamorphopsia, micropsia, and macropsia. So these are the chief complaints of the patient. Now coming to the clinical features, how you will make the diagnosis. How you will make the diagnosis. So first of all, you will do the fundus examination, right? You will do the fundus examination. On fundus, you will see on fundus. Now suppose this is right eye, this is optic disc. So you will see a round or oval type of, round or oval shape of macular edema. Round or oval shape of macular edema is seen on fundus examination in CSR patients. Now you will confirm your findings with the help of OCT and FFA. So the diagnosis is confirmed. So the diagnosis is confirmed by OCT and FFA. FFA is fundus fluorescein angiography. So what you will see in OCT and FFA? What you will see in OCT and FFA? Now this is the OCT picture of CSR. So this is the pigment epithelium, RPE. This is the choroid. So there is leakage of fluid from the choriocapillaries into the subretinal space. There is leakage. The fluid accumulates in subretinal space, which leads to neurosensory retinal detachment. This is a shallow neurosensory retinal detachment at the macula. Now coming to the fundus fluorescein angiography image. After OCT, you will do FFA. What you will see on FFA? This is very important from your exam point of view. Image-based question which is asked. This is an smokestack appearance. So you will see a smokestack appearance, which is also called as umbrella shape. Umbrella shape appearance, right? Also called as mushroom shape, right? So this is appearance which you see on FFA, fundus fluorescein angiography. Now if question is asked which is the most common appearance on FFA, then answer will be this one. This is the ink blot appearance. This is the ink blot appearance, which is the most common appearance on FFA. So these are the findings which you see, and you make the diagnosis of CSR. Now coming to the treatment part. Coming to the treatment part, you have made the diagnosis, coming to the treatment. So there is no treatment actually. You have to just observe the patient initially. Why? Because it is a self-limiting condition. It resolves spontaneously, right? So you have to observe the patient of the CSR. There is spontaneous resolution. Spontaneous resolution occurs, right? Other option, if you have to treat the patient, then what are the treatment options? Then you have to go for photodynamic therapy. Photodynamic therapy, which is called as PDT. This is commonly called as photodynamic therapy, PDT. Which drug is used in photodynamic therapy? It is verteporfin is used. Verteporfin drug is used in photodynamic therapy. In which conditions we use, we give treatment in CSR if there is any recurrence in the same eye or in the fellow eye, and if the neurosensory retinal detachment or the shallow detachment, it doesn't resolve even after 3 months, right? So you have to wait for 3 months, and after 3 months we go for photodynamic therapy, or the second option is argon or diode laser photocoagulation. Argon or diode laser photocoagulation. So these are the treatment options, right? So this is all about CSR that you should know. Now coming to the next question. Question number 193. This is an image-based question. All of the following are true about the patient with the given fundus image. So this is as you can see, this is a fundus picture given of a high myopic patient. So this is a fundus image of high myopic or degenerative myopia, which is also called as pathological myopia. So coming to the options, patient has a myopia of 7 diopters. Yes, this is correct. Option number B is the axial length is 23 millimeters. No, this is not true. Option number C is concave contact lenses are superior to spectacles for myopia correction in the patient. Yes, this is also true. Option number D is that it can be associated with Marfan syndrome. Yes, it is also true. And option number E, it has a prevalence of about 10%. This is false. So let us discuss the question number 193 briefly about the myopic fundus. 193. The correct options of 193 are option number A, option number C, option number C, and option number D. Right? So what happens in myopia patient, right? So this is the fundus image is of pathological myopia. This is pathological myopia. So what is pathological myopia? The myopia in which there is axial length of more than 26 millimeter. The patient has axial length of 26 millimeters, more than 26 millimeters, and the myopia which is more than 6 diopters is pathological myopia, right? So what happens? The treatment option, coming to treatment options, you know that we use concave lenses. The minus lenses are given. So in pathological myopia, as there is axial length is increased more than 26, the normal axial length, what is the normal axial length? The normal axial length is around 24 millimeters. So there is stretching of the eyeball. Due to stretching of the eyeball, what you see in the myopic fundus, as you can see on this image, the myopic fundus, you can see peripapillary atrophy. Due to stretching of the globe, there is RPE atrophy, right? Due to retinal pigment RPE, there is atrophy of the RPE, due to which what happens, that the choroidal vasculature is more visible, right? Choroidal vessels are more visible in this fundus, right? The optic disc is obliquely placed and it is associated with a myopic crescent. There is temporal myopic crescent, there is more visibility of vasculature of choroid, then there is chorioretinal atrophy is also seen, right? The appearance of the fundus is tessellated, or the tigroid appearance is there. Now coming to other options, they have given concave lenses, the contact lenses are preferred. Why? Contact lenses are preferred over the glasses. Why? Because they avoid contact lenses, they avoid peripheral distortion of image, they avoid peripheral distortion of image and minification of image and minification. They avoid minification of image, which is produced by strong minus lenses, right? Now coming to the systemic associations of myopia. So write down, next heading is systemic associations of myopia. Systemic associations of myopia. Coming to systemic associations, number one is the most important one. It is associated with Marfan syndrome. Marfan syndrome. Second, it is associated with premature babies, prematurity. Then the third syndrome, it is associated with Ehlers-Danlos syndrome. Ehlers-Danlos syndrome. Then it is also associated with Down syndrome, right? Now coming to the prevalence of myopia. The last option they have given, prevalence of 10%, which is wrong. The actual prevalence of myopia, write down, it has a prevalence of 2 to 3% in general population, right? So this is all about this question. You should keep in mind about pathological myopia. Now coming to question number 194, true about ciliary body. So true about ciliary body, option number A they have given, it is located 10 millimeters from corneoscleral junction. Corneoscleral junction. Sorry. True about ciliary body, it is located 10 millimeters from corneoscleral junction. This is false statement. Option number B is true. It consists of pars plana and pars plicata. Yes. Option number C is contraction of ciliary body helps in accommodation. Yes, this is also true. Option number D is it secretes aqueous humor. Yes, this is also a true statement. And option number E they have given that it derives its blood supply from short posterior ciliary arteries. This is a wrong statement. Now coming to ciliary body, let us discuss ciliary body in details. The anatomy of ciliary body. Question number 194, the correct options, the correct answers are option number B, option number B, option number C and option number D. So what is ciliary body? Ciliary body is the forward continuation. Ciliary body is the forward continuation. This is a continuation of choroid. It is a continuation of choroid at ora serrata. At ora serrata. Remember ora serrata, it is the anterior termination of retina, right? Now suppose this is an eyeball. This is our eyeball. This is iris. And these are the ciliary body, ciliary processes, right? This one is ciliary processes, and this is the anterior part of ciliary body. Remember, the anterior part of ciliary body is pars plicata, whereas the posterior part is pars plana. It has two parts, pars plicata and pars plana, right? So coming to the basic functions of ciliary body, what are the functions of ciliary body? So it has two main functions: aqueous production and removal, and second important function is accommodation. It helps in accommodation of eyeball, right? It helps in accommodation of the eyeball. Now coming to the anatomical part, what is the location of ciliary body? Write down. Ciliary body, it lies 1.5 millimeter posterior to the corneal. It lies posterior, 1.5 millimeter posterior to corneal limbus in the horizontal meridian. In the horizontal meridian, it lies 1.5 millimeter posterior to corneal limbus, right? And it lies 2 millimeter posterior in vertical meridian from the limbus, right? Now coming to the arterial supply or the blood supply of ciliary body. What is the arterial supply of ciliary body? So the arterial supply or the blood supply is via long posterior ciliary artery and anterior, it is via anterior ciliary arteries, right? So talking about ciliary processes, these are finger-like projections. And they are 70 in number, right? They are 70 in number. So this is all about the anatomy of ciliary body that you should keep in mind. Now coming to the next question. Coming to the next question, question number 195, which is true about optic disc. True about optic disc they have asked you. So option number A, horizontal diameter 1.76 millimeters. Horizontal diameter 1.76 millimeter, yes, this is true statement. Option B, vertical diameter 1.8 millimeter, yes, this is also a true statement. Option number C, it contains 1 million nerve fibers, yes, this is also true. Option number D, they have given central retinal artery directly supplies this area. This is a false statement. So let's discuss question number 195. Question number 195, the correct options of 195 are option number A, option number B and option number C. So suppose this is optic disc. Suppose the centrally lies optic cup. This is optic cup and this is the optic disc. This distance between the optic cup and the disc margin, this is known as neuroretinal rim, NRR, right? So let's discuss the size of optic disc. So the optic disc is 1.5 millimeters horizontally. If you measure it horizontally, it is 1.5 millimeters and 1.8 millimeters vertically. Vertically it is 1.8 millimeters. And the option number C, they have given that it contains nerve fibers. So optic disc, as you know, this is the intraocular part of optic nerve. So write down, important thing is that optic disc, you have to remember, this is the intraocular part. this is the intraocular portion of optic nerve, right? And it contains this optic disc. This contains 1.2 million axons. It contains 1.2 million axons, right? Now talking about the blood supply, talking about the blood supply of optic disc. So optic disc receives its blood from circle of Zinhallur. It receives the blood supply from circle of Zinhallur, which receives the major source of blood from choroidal vessels, right? And four or five short posterior ciliary arteries, right? And some part is supplied by pale plexus network, pale arterial network. So this is about the blood supply of optic disc. Now coming to next question. Next question, question number 196. Childhood malignancy producing proptosis is or are. So what is proptosis? Proptosis is the forward protrusion or the bulging of the eyeball in relation to your lateral orbital rim. So let's see what are the options. 196 they have given. Option number A, neuroblastoma, yes, it causes proptosis. Option number B, this is also correct. Option number C, optic nerve glioma, this is also correct. D, retinoblastoma, this also produces proptosis. And last option, Wilms tumor, this also produces proptosis. So let us discuss 196, proptosis and tumors. Let's discuss the causes of proptosis. Question number 196. Correct options are A, B, C, D and E. All of them are true. So let's discuss the tumors which produces proptosis. Tumors producing proptosis, right? So first of all, what is chloroma? Chloromas, chloromas are also called as, they are also known as granulocytic. They are called as granulocytic sarcomas. They are granulocytic sarcomas, or they are myeloblastoma. They are called as myeloblastoma. So these chloromas, these are localized collections of leukemic cells. Note down, these are chloromas, these are localized collections of leukemic cells, and they are seen exclusively in patients with AML. So these are seen exclusively in patients with AML, right? Now, other causes, let's discuss the other causes. Proptosis is also seen in retinoblastoma patients, seen in Wilms tumor, Then other causes, they are also seen in lymphoma, patients having lymphoma or lymphosarcoma. Then also seen in secondaries from neuroblastoma, patients having secondaries from neuroblastoma, neuroblastoma or Ewing's sarcoma, also seen with Ewing's sarcoma, right? So these are the causes or the tumors which produces proptosis that you should keep in mind. Now coming to next question. Question number 197 they have given, and they are asking you about Leber's optic neuropathy. Leber's optic neuropathy. So option number A is X-linked disease, right? X-linked disease, false statement. Option number B, primarily affects male. Yes, this is true. Option number C is that the disc becomes pale and atrophic. Yes, this is also true. D option, transmitted from mother to child. Yes, this is also true statement. And option number E is mitochondrial inheritance. So yes, this is also a true statement. So let us discuss question number 197. 197 answers are option number B, C is also correct, then D is correct, and E is also correct. So let us discuss briefly about the Leber's congenital optic neuropathy. Leber's LHON, it is called as Leber's hereditary optic neuropathy, LHON. So what happens in Leber's hereditary optic neuropathy? The optic disc, it becomes pale, right? Optic disc becomes pale. The retinal vessels, they becomes attenuated. They become attenuated and the macula is affected. Macula is affected, right? Now it is a type of LHON, Leber's hereditary optic neuropathy, LHON. This is a type of hereditary optic neuritis. This is a type of hereditary optic neuritis. So which primarily affects this LHON, this primarily affects males somewhere around 20 years of age. Somewhere around 20 years of age patients, male patients are affected. And coming to talking about the inheritance of this disease, which is important and you should keep in mind. The inheritance, it has a mitochondrial inheritance. It is a mitochondrial inherited disease which is transmitted from mother to offspring. It is transferred from mother to offspring, right? What happens in this disease? That there is degeneration. There is degeneration of retinal ganglion cells. There is degeneration of retinal ganglion cells, and it is a mitochondrial inherited disease, right? Now what happens? That there occurs progressive visual failure initially. Patient has progressive visual failure, right? Eventually this becomes pale, right? Eventually there is bilateral primary optic atrophy. Bilateral primary optic atrophy occurs eventually. So important point which you should keep in mind in LHON is that there is transfer from mother to offspring, and it is more commonly seen in male patients. Please write down. This is commonly seen in male patients. Seen more commonly in males, are more commonly affected. More commonly seen in males. So this is about Leber's hereditary optic neuropathy. Now coming to next question. Next question. Next question is 198. Not true about ectopia lentis in Marfan syndrome. Not true about ectopia lentis in Marfan syndrome, they are asking. So write down ectopia lentis. First you should know what is ectopia lentis. Ectopia lentis is displacement of the lens from its normal anatomical position, right? So there is displacement. Either it can be a subluxated lens or it can be a complete dislocated lens. So what is the difference you should keep in mind? In subluxation there is slight displacement of lens and some part of the lens is visible in the pupillary area. Whereas in dislocated lens, the lens appears aphakic, there is complete dislocation, right? Now coming to the options 198, let us discuss question number 198. The true options are option number A and option number B. These are not true, right? So to solve this question, what you should know about the ectopia lentis, what is ectopia lentis and what are the main causes, what are the congenital causes of the ectopia lentis and what are the spontaneous causes of ectopia lentis. So write down what is ectopia lentis. Ectopia lentis. This is displacement of lens. This is displacement of lens from normal anatomical position. From normal anatomical position. Right? Now coming to the causes. What are the congenital causes or congenital lesions? What are the congenital lesions with systemic anomalies? So it is associated ectopia lentis most commonly seen in Marfan syndrome. Marfan syndrome, what you should keep in mind about the ectopia lentis, you should know the direction of ectopia lentis. What is the direction of displacement of lens? So this you have to keep in mind. The lens is displaced. The lens is displaced upward and temporally. Upward and temporally, right? Now suppose this is the eye. What will be the direction? Suppose this is the eye and this is the lens. This is the normal lens. In Marfan syndrome, it will be displaced like this. The lens will be displaced outward and upward, right? So this direction you should remember according to the syndrome. In Marfan syndrome, the direction is upward and temporally. Second cause is also very important. Second cause is homocystinuria. Homocystinuria. So the direction of ectopia lentis in homocystinuria is downward. Direction is downward and nasally. It is not temporally, it is nasally. Now, third syndrome which is associated with ectopia lentis is Ehlers-Danlos syndrome. Then you should also remember other cause, hyperlysinemia. Hyperlysinemia. And the last cause is, which you should keep in mind, is sulfite oxidase deficiency. Sulfite oxidase deficiency. So these are the congenital causes. Now coming to the spontaneous causes of ectopia lentis. Spontaneous causes. So it is seen in hypermature senile cataract. Hypermature senile cataract, because zonules are very weak in hypermature cataract, so there is chances of displacement of lens. Second cause can be ophthalmos, then high myopic patients. high myopic patients because there is increase in axial length, enlargement of the eyeball occurs. Then other cause are intraocular tumors and uveitis. So these are the causes of ectopia lentis, right? These are the causes of ectopia lentis that you should keep in mind. So out of all the causes, the most frequent cause of heritable ectopia lentis is, the most frequent cause, remember, is the Marfan syndrome. The most frequent cause is Marfan syndrome, right? So write down what are the other features. Please write down what are the other features of Marfan syndrome, other ocular features of Marfan syndrome, other ocular features of Marfan syndrome. So what happens that this is the most common cause, as we have discussed. In systemic association, if they ask in syndromic association, the most common syndromic association is Marfan syndrome. If they ask you the most common cause of ectopia lentis, answer will be blunt trauma. Answer will be blunt trauma. If they ask you the syndromic association, then the most common one is the Marfan syndrome, right? Now coming to next question. Next question, they are asking about electroretinogram, which is called as ERG. ERG they are asking you, right? So let us discuss briefly about ERG. Question number 199. The correct options are option number A, option number B, option number C, and option number D. These are the A, B, C and D. These are the correct options. So let us discuss briefly about electroretinogram, ERG. So what is ERG? ERG, it is a measure of action potential of retina. It is the measure of action potential of retina, which is produced upon stimulation of light, which is produced after stimulation of light. So ERG, it is measure of action potential. It is measure of action potential of retina upon stimulation by light. So how does the normal ERG looks like, that you should keep in mind. So this is the normal graph, this is the stimulus, right? Now this is the normal ERG and this one is the baseline. This is the baseline. So as you can see, this first image, this first wave, this is the minus wave, which is called as A wave. This one is the B wave and this is the C wave. A wave, the deflection is negative and it is in the direction below the baseline, so it is negative wave. So what you should keep in mind is, you should know what is A wave, B wave and C wave, right? So in normal ERG, what does these signify, right? So A wave, it is a negative wave. A wave is a negative wave and this arises from rods and cones. It tells you about the activity of photoreceptors, which are rods and cones. Now coming to B wave, this is a large positive wave. B wave is the large positive wave and which is produced by, it is generated by It is generated by Mueller cells. B wave is generated by Mueller cells, and it tells you about the activity of RP, and it tells you about the activity of bipolar cells. So write down, but it represents the activity of bipolar cells, right? So B for B wave and B for bipolar cells, you can easily remember this. The B wave is important. It represents the activity of bipolar cells. Coming to C wave. So this is also a positive wave, and it represents the metabolic activity. It represents the metabolic activity of retinal pigment epithelium. Retinal pigment epithelium, right? And one thing that you should remember, that in ERG both scotopic and photopic responses are elicited. Both responses are elicited, right? Now coming to the uses of ERG, you should keep in mind what are the uses of ERG. So it is very useful in detecting the functional abnormalities. It is useful in detecting the functional abnormalities of outer retina. By outer retina, we mean that up to bipolar cells, up to bipolar cell layer, right? So you can detect the functional abnormalities of outer retina much before the appearance of ophthalmological findings, right? So there is early detection you can do with the help of ERG, right? So what happens that ERG, because it tells you about the abnormalities of outer retina, so ERG will be normal. ERG is normal in diseases involving ganglion cells. In diseases involving ganglion cells, right? Ganglion cells plus higher visual pathway. It will be normal in diseases involving ganglion cells plus higher visual pathway. Higher visual pathway. It will be normal, right? Now coming to the diagnosis or the uses of ERG, it is useful for, write down what are the clinical applications of ERG. It is useful in retinitis pigmentosa. We do it in retinitis pigmentosa. So write down clinical applications of ERG. Clinical applications or clinical uses. It is used for diagnosis as well as prognosis. Used to make diagnosis as well as it tells you about the prognosis of diseases like retinitis pigmentosa (RP) and Leber's congenital amaurosis. Leber's congenital amaurosis and retinitis pigmentosa and other chorioretinal degenerations. Other chorioretinal degenerations, right? Now next use is that it is used to assess the retinal functions. It assesses the retinal functions, write down. It is useful in detecting the retinal functions. It tells you about retinal functions. You can assess retinal functions in patients when fundus examination is not possible. So what are the conditions in which fundus examination is not possible? It can be a dense cataract. Patient can have a dense cataract. or there can be corneal opacity, right? So these are the causes of, or these are the uses or the clinical applications of ERG that you should keep in mind. Now coming to the next question. Question number 200. Ectopia lentis. They are asking you about ectopia lentis. Again, we know what is ectopia lentis, we have discussed. It is associated with, option number A they have given, homocystinuria. Yes, this is associated with homocystinuria. B option is Alport syndrome. No, this is false. C option, Lowe syndrome. This is also false statement. D option is Marfan syndrome. Yes, this is true. We have already discussed this. And E is sulfite oxidase deficiency. This is also we have discussed. So the true or the correct options, write down question number 200. The correct options, option number A, option number D, and option number E, sulfite oxidase deficiency. So as we have already discussed the systemic associations of ectopia lentis, number 1 is Marfan syndrome, number 2 is homocystinuria. This one is easy. We have already discussed Marfan syndrome, homocystinuria, then is Weil-Murchesani syndrome. This is also associated with ectopia lentis, right? So what happens in this syndrome is that the ocular features of Weil-Murchesani syndrome are, patients have spherophakia. Spherophakia means spherical lens. So there is spherophakia plus there is forward subluxation of lens. There is forward subluxation of lens. This forward subluxation, because lens is spherical, there is forward subluxation of lens towards the anterior chamber. It can cause, or it can cause secondary angle closure glaucoma. So it can cause secondary angle closure glaucoma if it causes pupillary block. Pupillary block glaucoma, right? Other syndromes which are associated are Ehlers-Danlos syndrome, Ehlers-Danlos syndrome, Ehlers-Danlos syndrome, and hyperlysinemia. Hyperlysinemia. So what happens in Ehlers-Danlos syndrome? In Ehlers-Danlos syndrome, there is subluxation of lens. There is subluxation of lens, plus the patient have blue sclera. Patient have blue sclera in Ehlers-Danlos syndrome. Now in hyperlysemia, this condition is also a rare condition. Hyperlysinemia, this is also a rare condition which is associated with ectopia lentis, right? In sulfite oxidase deficiency, write down, in sulfite oxidase deficiency, ectopia lentis is a universal ocular feature. It is a universal ocular feature, right? So this is all about the causes of ectopia lentis, right? So this is all about the ophthalmology part of grand test number 182. Best of luck. Thank you.